So Dr. Sharma needs no introduction, and he's the director of intervention for the whole health system, and has been for at least since I've been here, maybe for the last 25 or 30 years, I don't know. But anyway, he's going to talk to us about transcatheter advances in transcatheter therapy in the last year. And as you know, transcatheter therapy has become integral in everything we do, and is an alternative to almost all the surgical procedures that we do. So it's something that comes up every day in our discussions with patients. So I thought it's good if he just brings us up to speed with what's been going on in the last 12 months. So, Dr. Sharma.
Okay, Ani, thank you very much. This is 20 years, but the first time I'm coming here to give the lecture. And of course, Ani and Dr. Adams finally made it, let's say 20 years. The goal will be to just give you update. This field is evolving of transcatheter valve therapy. We did our first New York valve meeting, was very successful for its first of its kind on December 6th, about 225 people. So, and I put together, and I updated since then, actually, almost 30 slides have been interchanged since then. And idea is just to take you through what Dr. Ani started, the statement that most of the valves are being tackled or being investigated to be tackled by transcatheter therapy. Starting, first data, actually, if you see, was with the pulmonic valve, which was very easy, with the Melody valve, and then went to the aortic, then the mitral, and the tricuspid. So all four valves, which are surgical, which of course you guys are expert in, but appropriate cases are being evaluated and being treated in clinically or in the trial format by using the transcatheter valves. Now, where is the history? History started in 1989, where this guy, Anderson, thought that why can't we put the valve suture to the pericardium and put in the sheep. That is how this whole field started in 1989. That was the first time anybody thought about the stent. Actually stent, before stent, it was the balloon that was done by Andreas Grundzig in Zurich. So key is that it really has a long history of interventional cardiology, and now for the transcatheter valve by Anderson, and this was called Anderson stent valve. Did a lot of sheep experiment. That is the valve going to fit? How is it going to open and close? So many issues which comes. So they have many, Alan Cribier is another very, I would say, forthcoming interventional cardiologist from France at that time, made many designs, early stages, that how the valve is going to make. And I call him as a father of transcatheter valve therapy, because he is the one who started, he made the company, percutaneous valve technology, and did the first in man case on April 16th, 2002. So after 89 to 13 years took from the sheep to the human being, 13 years. So basically, after the first case, he had non-surgical implantation of a prosthetic heart valve can be successfully achieved with immediate and midterm hemodynamic and clinical improvement. And midterm, because they then published the paper, they had a 6 months data, but this was right there, apparently half hour later after the valve this transcatheter valve replacement. And that time, early days, they were being done as a transeptal. So you see here, very complex issue coming through the transeptal, retrograde, and then go to the valve. See, so it was transeptal, very complicated procedure. Many times this stiff wire caused a severe mitral regurgitation. So valve is working good, but patient is in shock because the wire cut off the cord A, because very stiff wire. So this technique was very rapidly abandoned within 2 years by 2004, and everything was done then retrogradely by transfemoral or other approaches, but going back not to the transeptal. But this was the first case was done in April 2012 by the transeptal approach. So with that note, so what we are going to do is go through some of the data in 2018, and that actually has been when I started my CCC Complex Coronary Symposium. So always put at top 10 advances of interventional cardiology. And now I have collected 2018. Maybe one or two slides will be older than 2018. All will be of 2018, just to give you latest what is going on. And selection is through the change, because there's some publication which are led to the change in clinical practice. And these are from numerous journals, presentations, abstracts, and so on and so forth. The first one is the tricuspid valve intervention with the Lumen trial. So the data from the STS, that if you see here, the isolated TVR and replacement or repair, that mortality kind of remained constant. So we all know, and I'm sure you know better than anybody on the tricuspid. So while other valves are good, everybody wants to do it with the tricuspid. Everyone takes the back seat, whether it's a heart failure doctor, cardiologist, or surgeon. So because the results are not great with the tricuspid valve, then there has been a lot done now on the transcatheter tricuspid valve. And this is a very nice review article, and basically takes into the various mechanism that how can you tackle the tricuspid. So basically, the early first stages were heterotropic cable valve implant, that you put a valve into the superior inferior vena cava. So you're not working on the tricuspid directly, but indirectly by decreasing the regurgitation. So this was the first of its kind started. Then second was cooptation device, and one of them called Formica, where basically kind of a balloon on the tricuspid valve. So it's space occupying, nothing to do with the valve. It's just decreasing the regurgitant orifice, and then led to the various clip, which I'll briefly discuss. Then, of course, the suture, just like we do for the mitral valve, and the replacement of the valve, and annuloplasty, followed by the transcatheter tricuspid valve replacement. So field is evolving in all, starting with the vena cava implant. I would say it has gone into this clockwise direction. There are very scanty report of the TTVR, but it's there. So what has been maximum data is edge-to-edge repair. Tri-valve registry is basically same what we use for the mitral clip. That clip used for the tricuspid valve. And basically, based on the cooptation, that where is it? Because we know that if the gap is more than 7 millimeter, it's difficult to get a good results. But if less than 7, you can grasp the tricuspid valve. And overall, the data have shown satisfactory results, particularly if it is less than 7 millimeter gap. When more than 7, your success rate really goes down. So key is, some cases of the tricuspid valve can be grasped by your regular mitral clip, and this is a part of the tri-valve registry. Then you say, well, why don't you make a clip suitable for the tricuspid valve, which has the bigger prongs compared to the regular mitral clip, and that is the Triluminate trial with a tri-clip. And this is the trial has started for 85 patients, 15 centers, 4 in US, and the Gilbert is the PI here, with the primary endpoint being a TR reduction. See, come in right timing. More than 1 grade at 30 days, and of course, mortality follow-up up to 3 years. So we have done 4 cases so far for the Triluminate, and this is again easier way, very low complications, and appropriate cases can be done. So a lot of data are coming into the tricuspid field, which I mentioned that where it should fit, primary or secondary. All these devices have come up where is kind of indication by first in man data based on the pathoanatomy of the tricuspid regurg, where these devices need to be used. So tricuspid field has started. Sentinel cerebral protection device. So basically, we know when we do the tower, the embolism takes place, just like even surgery, because the 2 regions, one, the calcific valve, and secondly, we advance the device to a very diseased aorta, because it was done for the elderly patient. And if you put a filter into the carotid, the data have shown almost 100% time, you'll get some embolic material. And that material could be the calcium, could be a tissue, thrombus, the clot. So many the factors could give rise to this embolism during tower. And the overall stroke rate is about 4%. So once you have a good neurologic assessment, of course, once you have a more rigorous assessment, maybe higher, but about 4% with a deficit. If you take a micro only with the MRI, that happens in 60-70% of cases, some MRI deficits. But for the gross deficit occurs in about 4% of cases. So that led to a trial using the Sentinel device. And look at this, very fancy. It goes from the right radial, the one part stays in the right innominate, and then goes into the left side and basically left carotid. So idea is that any embolism comes, it can be captured. Then there is a whole technique, and the catheter, you can close it and take it out. Only thing is you don't basically take care of the vertebral, particularly the left side. And what trial data showed, because it was a trial of about 200 patients, that there was 42% reduction, but did not make a p-value. More importantly, that basically the gross or the neurodeficit decreased from 6% to 4%. So clearly about 33% reduction, 30-day MACE were identical. That led to approval of the device. And since then, we actually have multiple papers. In 2018, few of them actually showing even reduction in mortality by using the device. So overall, 5% has become 1 to 2%. So since it was approved last year in June, and there is an added cost of $3,500, we went through the process that how do you add the cost of this device to already expensive $30,000 TAVR valve. So it seems to be that appropriate cases, you cannot use Sentinel in everybody, but about 30% are excluded because of their anatomy, because the way this catheter has to fit in. About 70%, if you make it a routine use, particularly patients who are AFib, multiple CVAs in the past, and so those are appropriate. So that is where we started routinely as of September last year. So now every case, if you are not using Sentinel, we make in the report that why Sentinel was not used. So we make it a default therapy. And you can see many centers like Sinai and so once they started using routinely, 5% became 1%. So we still have to collect data at our center. And because I'll show you the tower comparison with the STS. We are a little higher stroke rate, maybe whatever the regions are. But I can tell you in last 4 or 5 months has done tremendously well when you're making it a routine use of the Sentinel device, and of course, and really document why you're not using it. So question also comes that various devices have different types of CVA incidents. So there is one paper came out last year about really analyzing this debris, which is captured in this Sentinel dual filter, and it shows that you can see everything. The vessel valve, calcification, myocardium even, necrotic core. So all can be captured in this debris in the filter, proximal or distal filter, as you can see. Now, second point important was the size of the particulate size. Now, you see here, basically the 3 types, the self-expanding and the Sapien valve and Edward and those and Boston Scientific Lotus, that seems to be that in Edward Sapien, the particle size is a little bigger. So does it mean that it causes a little more CVA compared to the smaller one? This will show some data. They're very conflicting, but some studies did show slightly higher CVA rate with the Sapien valve compared to self-expanding valve. Although it's not inconsistent, but it shows that many times in the Sapien, when we deploy based on the study, that you have a bigger particulate size with a Sapien. So then antithrombotic therapy post-hour, just like for any that you want to give more, you're putting a foreign material, you want to give more antithrombotic therapy because you think that it is going to create less embolism. And so antithrombotic plus more bleeding risk, maybe in terms of mortality. If you don't give antithrombotic, your thromboembolic risk and structural valve deterioration. So single antiplatelet therapy to the dual to the anticoagulant. So basically what has happened without any clear-cut randomized trial, when the process started of the tower, both actually for mitral clip as well as for tower, so we made aspirin plus clopidogrel, aspirin 81 milligram lifelong, and clopidogrel 75 milligram 3 to 6 months was routine but some cases have been done with a single antiplatelet therapy also. So then whole question was, knowing that back many years ago, when aortic valve bioprosthetic need to be done, they used to use a short-term 3 months antithrombotic therapy. So question is, should you use antithrombotic therapy routinely? Not because it was indicated for AFib and other region, but routinely. And so So what has shown that bioprosthetic valve dysfunction, which is defined as mean gradient more than 10 or new mean gradient of more than 20, and prevalence occurs in about 5% of the TAVR patients. And it basically causes, there is a thrombus and you have decreased movement of the leaflet. So leaflet thickened and decreased movement cause gradient, and it's associated with some CVA. So a lot of data actually have supported the use of anticoagulants, because they found that if you are on anticoagulation, the chances of valve deterioration is less. So this was the old concept. So it makes sense that maybe we should be using oral anticoagulants, whether it's a warfarin or NOACs, in these patients to reduce this stroke rate. So there are the two pieces of information in 2018 to really answer this case. France TAVI registry, this was the data of, again, no randomization, but the patients who were on there were many protocols, they were using anticoagulations, and then they were compared the patients who were getting anticoagulant versus not anticoagulant for two purposes. One, follow-up at 3 to 4 years, and secondly, valve dysfunction. So guess what happened? You use anticoagulation, you have a higher mortality. Not for AFib patient. So valve, in the registry, use anticoagulation, higher mortality. Second, yes, if you use it, you have a better, in terms of your valve dysfunction is less. So now you have dichotomy. You have better valve, but patients are dead. Not good thing. So it seems to be, say, well, you know what, it's about non-randomized data. So people brushed it off, it's a registry. There was a lot of editorial on that issue. So, well, again, this is basically the two dichotomy, as I mentioned. There are actually 6 trials are ongoing to answer that question. In AFib patients or non-AFib patients, using anticoagulation routinely in these patients and comparing with the single or dual antiplatelet therapy, the most important was the Galileo. Took the initiative, rivaroxaban 10 milligram with aspirin or 3 months of DAPT. And after 30 days, remains only rivaroxaban up to 1 year, and then aspirin. You take the clopidogrel out after 30 days. So basically what we are comparing, patients not in AFib, giving routinely 10 milligram rivaroxaban instead of clopidogrel. Simple. Makes sense. That's what we wanted to do, right? That's what in the surgery, I'm sure, I don't know whether used to use Dr. Stelzer antithrombotic therapy. I know back in 1992, Dr. Greep used to give in bioprosthetic 3 months. But I think after a few years, that was even taken off. But they used to give antithrombotic therapy. So that was the whole concept. So give it for 3 months, and the trial was terminated because of the higher mortality. And guess what happened? You have a all-cause death, higher bleeding by giving routine anticoagulation. So this field, for the time being, everybody has taken a back seat. That giving routine antithrombotic therapy is not a good thing. Then we have NVSAs. This is a trial is still ongoing. The patients who are on indication for oral anticoagulation, warfarin versus NOACs, because there is no data that should be warfarin or NOACs. Because remember, NOACs for the prosthetic aortic valve or mitral valve, so it's not indicated. So question is, can you use NOACs at least in the transcatheter valve? And this is what trial ongoing. We are part of it. It's still ongoing at present. This will be the very interesting one. Atlantis is still ongoing. And that is the 2 types of patients who needs oral anticoagulation will be randomized to warfarin plus apixaban 5 milligram twice a day, who are not oral anticoagulation, apixaban 5 versus single or dual antiplatelet therapy, 1,500 patients. So will give us answer in next few years. So this actually has come up with some of the guidelines already, that if you want to give I'm sure this is earlier. At present, everybody will say, don't give any anticoagulation to these patients, and single antiplatelet therapy is good enough in many of these patients. So TAVR for pure aortic regurgitation. So problem with the aortic regurgitation is pure AS calcific keeps the valve. If you are pure aortic regurgitation, you are in trouble, because what anchors the valve? There's no calcium. So therefore, chances of a paravalvular leak, valve embolization is significantly higher. And this actually led to a registry of early generation versus newer generation transcatheter valve, and all types of valve has been used. Predominantly in the past, it used to be the self-expanding, but now even the balloon expandable valves are used, and overall showing that the outcome of the newer generation valve for pure aortic regurgitation are okay. This actually have put into a nice, again, central figure that overall early generation versus newer generation having a better outcome. But again, these are the patients who are extreme risk or high risk, not going for surgery. But yes, there are data now that native aortic valve regurgitation, you can use these current valves. But at the same time, studies are ongoing on few of them. Jena valve actually already have some publications, like for 5 cases, there are a little more. So basically, the newer valve, they have some hook. See that? So basically, go into the aortic wall. So keeps it there in this pure aortic regurgitation where there is no calcium, so it does not embolize. So then, a new tower indications. So few of them, the one is the patients with a moderate to severe AS, bicuspid aortic stenosis, valve-in-valve, moderate aortic stenosis with CHF, low flow, low gradient, and early tower in asymptomatic patients. So I'll take you quickly through the low flow, low gradient disease. Basically, EF is less than 50%. There's low flow, low gradient. We always believe that you do dobutamine, your gradient increases, stroke volume goes up by 20%. Those are the ideal cases. There's a true severe AS, and those patients then should be undergo tower based on their intermediate, high, or extreme risk. So question comes that if the patient, the gradient did not increase, but valve area increased because of stroke volume increased, so this is a pseudo AS. Should these patients be treated? And there is a trial called Tower Unload, and I'll show you that a little later. So then question comes that what about if you did not have a change in the stroke volume, which we do dobutamine stress routinely? So this actually is answered by a study called TOPAZ-TAVI registry, which was registry cases, 2-year follow-up, and you'll say that overall death rate of 39%, these patients probably acceptable. If you don't do the valve, probably it will be 60-70%. And these are the other individual endpoint. The COPD, low hemoglobin value, moderate to severe AR post were the individual predictor of the subsequent bad outcome. So now very interesting we learned from this, that when you give dobutamine stress echo for these patients with low flow, low gradient, half of them will have a contractile reserve, other half did not. So what also learned, what was the common teaching? Because surgical data were that if you don't have contractile reserve, those go for surgery, they do bad. Now what about the tower? You see here, your contractile reserve or not, at 2-year outcome were identical. Second, that increase in ejection fraction was not determined based on the contractile reserve. So it seems to be that patients who have low flow, low gradient, symptomatic, it's appropriate to just go and do the tower. And that was the editorial. The tower in, dobutamine stress echo out. So, but I mean, a little extreme, but just to say that our decision based on the DSE, and this is a non-randomized, large number of patients, the TOPAZ registry showed that good outcome for these patients, irrespective of the stroke volume augmentation. Now, what they also found that in this registry of this TOPAZ, that if you have paradoxical low flow, low gradient, the EF is more than 50%, but low flow, low gradient, they do very badly with a tower. So, or for that matter, anything, those patients don't go for surgery. Their treatment is aggressive reduction of their diastolic or management of diastolic dysfunction, so that because of left ventricular hypertrophy, high blood pressure, and so on and so forth. So then the question had been that the low flow, low gradient, I think everybody believes there is a CAD. You try to do PCI also, because many of these patients are ischemic. And sour tower compared to medical therapy do better. So now what about the failed bioprosthetic valve? So this, I'm sure everybody will agree that you have bioprosthetic, and so far we have the data. This is the valve-in-valve. This is actually the Sapien. Usually we use the core valve in these patients, and with a immediate very good hemodynamic results. Some gradient always remains about 10 to 25 millimeter mercury, but no regurgitation. And studies have shown when you compare, this is the valve-in-valve data, and this is the native valve, that valve-in-valve does very good, actually better than your native valve. So overall, so valve-in-valve, I mean, again, I may be biased in this. I'm sure many of you will also agree that these kind of patients already have a surgery. Probably valve-in-valve should be class 1. Irrespective of the STS risk score. But right now, we still have to go through the same, and it's approved only for a high-risk patient. But just the data are very clear that decreased hospitalization, decreased stroke and mortality of valve-in-valve compared to native valve. Only issue remain is higher the coronary obstruction in these cases. Whether it's less than 80 or more than 80, clearly the valve-in-valve does quite well. Now, also we learned balloon expandable versus self-expanding, that self-expanding have a lower residual gradient. So clearly that we prefer self-expanding valve in this situation compared to balloon expandable. What about the bicuspid valve? The problem with the bicuspid is it's a clearly surgical disease, partly because of the anatomy of the valve, associated aortopathy, and there is a lot of calcium, can create annular rupture, not a good seal, and so on and so forth. But again, there are patients which cannot go for surgery. So we actually, early generation versus newer generation device with a better seal, so less regurgitation, rightly placed valve apparently have a better outcome compared to earlier generation, as shown here, in terms of paravalvular leak and subsequent second valve implantation and so. Then is the one which is very tricky, is what you do for asymptomatic severe AS, which happens in about 40-50% of cases, and many patients, they are followed. Whether they may have severe AS, but there's no indication. You do stress test, negative. Patients say, I feel fine. Now, what to do with this? This is the asymptomatic AS. Now, there are data, if you follow these patients without intervention, latest being from Taniguchi, that overall you have a 3 to 5-fold mortality compared to your standard surgical valve replacement. So this is a very nice data, AVR versus conservative, that in 5 years, you have almost 11% mortality in favor of conservative wait and watch policy. Why that happened? Largely because aortic stenosis causing myocardial fibrosis. Second, even if you have created that the cardiac damage, you do a surgery, many of these patients, because more fibrosis has occurred, they correlate still with a bad outcome at follow-up. And there are many, the trigger points are coming, particularly checking the brain natriuretic peptide or serial echoes, looking for LVH. And so maybe those cases, you intervene. So that led to the whole issue is, should you intervene in these cases, asymptomatic? Surgery, we know that they say surgery has 1 to 2% mortality. And if you don't do it, there is a 1 to 2% death rate, kind of equipoised. If you can make something better, knowing that we have some data that maybe short-term mortality live better with the TAVR, these patients, led to this trial, early TAVR trial. And basically this is patient with a severe AS, if they're symptomatic or positive stress test, they get whatever need to be various trials, which were part of it. But if they're asymptomatic, are being randomized with a transfemoral TAVR versus clinical surveillance. So here is the asymptomatic. So key is that you are low complication of the TAVR. Maybe that's the case. If you have a less than 1% 30-day mortality, maybe it's a reasonable case for TAVR rather than continued surveillance. So this is a big trial ongoing, and Dr. Adams promised me after if the low-risk trial data comes out good in March, we have been invited. We work very hard to be part of it, that they will allow us to be part. 1,100 patients. They are having, these are very few patients. So they even company itself having a tough time to enroll, but they have done about 300 plus cases so far. But the whole idea is that should you do early TAVR in these patients and so. So this actually is a very interesting data. Second is the unload. We know the moderate aortic stenosis patient is coming back with heart failure. What to do with these cases? So there is a trial of 600 patients after optimal heart failure therapy versus you combine it with the TAVR with a valve area between 1 to 1.5. So this is the unload TAVR trial. They're actually having a tough time to enroll these patients, and we didn't ask to be part of it. But definitely early TAVR to me, I think makes sense. Then we are going with the various vascular access besides femoral or subclavian or direct or transapical already abandoned. The two new things which are coming is the transcaval, that you go from the vena cava, puncture, and then you put a plug in the end, but sheath from vena cava to the aorta and go retrograde. And second is the carotid. A lot of data are coming from the carotid, and then of course, appropriate patients putting a TAVR valve through the carotid. So then the TMVR trials. So basically, just like for the aortic, lot of devices are being in trials, first in man, in development for the mitral space. A few 10 cases, 20 cases, 50 cases, many of them then got stalled because they had a trouble, try to understand. So what really has gone to is the randomization, is the first valve, is the in the Apollo trial with the Intrepid of Medtronic. Dr. David Adams is the national PI with the surgical PI, and Dr. Marty Leon is the interventional PI. So this is the first trial of randomized the MIT TMVR. Of course, they have registry, high risk, intermediate risk, randomization against surgery, and of course, we need to see the data further on. So we do have some data on using the Sapien valve for various of these situations. MAC, valve in ring, or valve in valve. And basically, word is MAC is no good, plus minus for the valve in ring, very good for valve in valve. That led to the publication in European Heart Journal of this the large registry of a degenerated valve, 500 plus cases, valve in valve, valve in ring, and valve in MAC. And look at this one. Outcome, conversion to surgery, very bad in MAC. Second, 30-day outcome. This is valve in ring, valve and MAC. Success rate continues to decrease. Very high 30-day mortality, all complications. And now you see at 1 year, almost 2/3 of MAC patients have died. The question is what good it is. So you're doing a technique. I'm sure if you don't do, maybe they'll survive over 30-40% anyway. So message here is valve in MAC is no good. Appropriate case, valve in valve is okay, ring plus minus, but definitely the valve in valve, very good outcome. TMVR for these cases. And author tried to say, well, if you survive 30 days, then your outcome is not that bad. But I think overall, and we actually have at Sinai, not done any valve in valve for MAC. We do about 4, we did in 2017, and 6 last year, there's a TMVR of using the Sapien, and of course the Apollo trial ongoing. So quickly, few other which type of valve you should use. We have one old trial called CHOICE, which showed the data at 1 year, whether you're balloon expandable or you're self-expanding, the slightly lower stroke rate with a self-expanding valve numerically, but otherwise identical except higher pacemaker rate. And then we have a trial called SOLVE-TAVI, presented in TCT, 2x2 randomized trial, self-expanding versus balloon expandable, or general anesthesia versus local anesthesia. And basically, a very interesting trial to show. So whether you use any valve, self-expanding, Evolute or Sapien, similar outcome, although numerically you have lower stroke rate in this study with the Evolute compared to Sapien. Maybe it's because of the larger particulate size, which we show in the Sentinel device. But a pacemaker definitely higher with the Evolute compared to Sapien. And these are the individual endpoints. There was not much difference as shown here, but safety endpoint which they made slightly better for the Evolute. Then anesthesia. Basically, you do general versus our local, which is what we do in 75-80% of cases. Again, no difference, except that what they found that medication much user higher in the general anesthesia compared to local anesthesia. So basically, we have the clear-cut protocol. That's what myself, Keeney, and Gilbert, we follow, we decide every case which one we should use. And these are some data, particularly high calcium, you want to avoid using Sapien. And if you need to pace the ventricle, you want to avoid using Sapien. And anytime pacemaker, then Sapien is preferred, or very large annulus. Sapien is the good valve, but otherwise we have about 50-50, both of them as shown here. So coronary angiography post-TAVR, which is one big issue. There is a lot of papers about it. We did a lot of work because we have published the coronary angiography one time in the aortic aneurysm cases back in 94. Then we did in 2000 anomalous coronary arteries, coronary angiography. So this is our field. So we studied a lot of patients after TAVR. Post-TAVR, to do the angiography is very, very difficult to engage, particularly with a self-expanding valve. And we went through all cases, literature, and came up with a great plan. And this is actually a central figure made by Gilbert overnight when we were ready to send it. Fantastic, just to put it together, that how difficult it is to do angiography in these patients, because sometimes the valve leaflet can come in front of the left main. So we did an algorithm based on our experience, whether you do a self-expanding or the PCI or cath, or same thing for the balloon expandable. It seems to be balloon expandable is not a problem. It's the self-expanding we really have to work on it. The TAVR for low surgical risk patients. So basically, you remember the partner trial, and then our core valve showed benefit of TAVR Then we did that was the extreme risk. Then high risk, both were identical except higher stroke rate in early stages because of Edward Sapien, 24 French, while then subsequently the high-risk trial, Dr. Adams being PI here, no difference. Then we did partner 2A and Certavi, 2-year. Now we have just about 5-year data. Both were identical outcomes, no difference between two techniques, selected patients. So there are some data to say, maybe in the low-risk group, if your STS is less than 3, maybe while for surgery point of view, your outcomes are identical, but for the tower, your outcomes are much better if your STS is low. So this is just the sub-analysis of the Certavi. So basically, anyone intermediate, high risk, extreme risk, and so tower, or of course, appropriate cases, if tower cannot be done, surgery. But this group, surgery versus tower, less than 3% STS is being studied in total 4 trials. 1 already published, 2 already done, and then 4th one is ongoing called Notion 2. So basically, the original Notion trial showed 5-year data comparing tower 145 versus surgery 135, and you see the exactly identical outcome except higher pacemaker rate. So seems to be, and STS was 3 in these patients. So seems to be that low risk will be identical. Then, and the latest very, very, I would say, provocative data from Ron Waxman of the 5 center. They were actually asked us, but we could not participate in this. Ron Waxman did ask us to be part. They did permission from FDA for prospective tower enrollment. No randomization, 200 patient with a low risk STS of less than 3, and then compare with the historical control of the surgical valve. So, I mean, it's not a true apple-to-apple comparison, but this is what they did overall, as you can see here, and basically found lower length of stay, expected what you'll see with the tower. The more importantly, the leaflet, they did a same CT analysis that 7% of patients have some valve dysfunction, and they put the central figure very nicely. So in these 200 low-risk patients, what are the data? 30-day clinical outcome, 0 mortality, 0 stroke, permanent pacemaker in 5%, 0.5% mild paravalvular leak, and yes, there's some echogenic density occurs in about 7% of cases. So we need to be careful what to do about it, whether it's an appropriate full expansion, and we learn more that which patient develop that leaflet thickening, which can give trouble. But very, very provocative and encouraging data, which will lead to partner 3 trial have been done, 1,200 patient, 1-year endpoint of the transfemoral tower versus surgery, all-cause mortality, stroke, or rehospitalization at 1 year will be presented on March 17, 2019. Then ours, we were part of Medtronic Evolute low-risk tower, 1,200 patient. Primary endpoint was 2 years, death and stroke. But FDA allowed to them present interim data of the 1 year because field is so hot. 1-year data will also be presented for the Evolute. I don't know how FDA allowed it, but they did. So they will present 1-year data. So having said that, so as I mentioned that all high surgical prohibitive risk, intermediate, tower was class 2A, but European guideline already have changed it to class 1 based on the subsequent data now of even intermediate group with the Certavi, surgical AVR, or whether tower, this group is only one need to be established. Having said that, this is pending results of the low-risk tower trial in ACC. FDA has allowed direct access to tower in low-risk AS under continuous access registry for both Sapien and Evolute trial valves. So now we actually started doing these patients because we're losing these patients to Columbia. Columbia started about 3 months earlier, September, and we started only in November now. The low-risk patient appropriate, they still have to present to the company, and then if they're appropriate, can be part of the low-risk registry, but they have to sign consent for that purpose. So lastly, the most important advance, which I'll just go through very quickly because everybody has heard about that, is the mitral clip for functional mitral regurgitation, co-op trial. Basically, we all know that primary MR is a surgical treatment. Repair is better than replacement. And of course, the clip is used for prohibitive surgical risk cases. While secondary MR with medical therapy, CRT, and surgery is only in selected patients, what about using the clip in these patients who are recurrent heart failure? The 2 studies were presented last year. One is the MITRA FR, evaluate the efficacy of the clip, and basically showed that while success rate is quite good, about 96. Half of them get more than 2 clips. That's what the good, I would say, the results are. So less regurgitation. Outcomes were neutral. No benefit of the clip in these group of patients. Then with the 12 months follow-up or rehospitalization. Then 2 months later, this was in European Society of Cardiology. 2 months later, we have the data of the co-op trial, which is mitral clip with guided medical therapy versus medical therapy alone. Patient with a severe MR, very strict randomization. Because heart failure person has to give okay that we have failed all the therapy and CRT has been done in almost half of them. Now this patient is appropriate for randomization. So we basically showed, to music to our ears, that the primary efficacy endpoint of repeat hospitalization decreased from 68% to 36%. Second, and then overall efficacy point of view, and there are a little better outcomes procedural in the co-op trial compared to what we saw in the MITRA FR. And more importantly, look at the mortality, 46% if you didn't use the clip versus 29%. Remember when the tower first came in partner 1B, you know what was the difference? 50 versus 30 at 1 year. Similar data in these patients, particularly the patients who are for heart failure, all-cause mortality, and more importantly, which was very interesting, was the need for LVAD or heart transplant significantly reduced in the group who received the clip. So very dramatic data. So question always came, and they're still trying to analyze why these two trials were so different results. So one of the things which I have to, again, I'm not an echocardiographer, but what I could learn is that in the MITRA FR, these are the cases, regurgitation was a little less, but the LV cavity was too big. So you can call it a burnt end stage cardiomyopathy. So clip did not make difference. While in the co-op, they were still not into that burnt stage. And we actually have that data. For hypertension trial, simplicity. When we did the trial in the 4 patients who require 4 drugs, the device failed to do the renal artery ablation, renal nerve ablation. But now when we did it for moderate hypertension, the denervation worked. So I think it has to be, once you got to the extreme group, it's not going to make any difference. And so of course, this we are hoping get a use approved very quickly. Whether it will happen or not, we do not know. And then really will make a big difference. And I think that was the biggest trial which nobody predicted. I can tell you the tower pundits, or structural gurus who thought nobody could think that there is a clip will decrease mortality almost in half, besides decreasing the hospitalization in these patients. So just put it together very quickly, that what did we learn? In 2018, change in clinical practice, TMVR for MAC, anticoagulation for tower, MITRA FR, no good, negative. TMVR, TTVR, balloon, the tower for bicuspid aortic valve, TOPAZ, but low flow, low gradient, SALT AVI, we got some answer that reasonable. Then Sentinel protection device, tower for pure AI and coronary angiography, 2+. The real data, I would say, the valve-in-valve tower, very promising. Co-opt in FMR and tower in low risk, all seems to have very good future with the great results for better intervention and patient survival. So hopefully in the time to come, we'll hear more and more about this field expanding further, and I'll stop it here now. Thank you very much. Any questions? Yes.
The question that always comes up on both the surgical and the intervention side is durability. And unfortunately, we hear so many different answers. I've heard from cardiologists saying surgical aortic valve lasts 6 years to 10 years. We know that the average is about 12 to 15 years, maybe 20 years. And why is there such a discrepancy? And that seems to be, no one knows the durability of TAVR valves. And we're moving younger and lower risk. So we surgeons always ask the question, is this an appropriate therapy for somebody who's 55 if we don't know the durability? I mean, we know the durability in surgical valve, but there seems to be such a big dichotomy in who answers that question. If you hear from a cardiologist, it's 5 to 6 years for some of the surgical valves, which we know is not true. If you hear from a surgeon, we say 15 to 20 years. So
that may not be completely true.
Exactly.
Yeah. But that's a very important point. Now, all the trials of the tower, the high risk, extreme risk, intermediate, they were randomized so quickly. While low risk had a tough time. And precisely for this, because I know even our cardiologist, we say, it's a great case for to be part of low risk. But cardiologist said, no. It's a 65-year-old. I don't know what tower going to last for 10 years. Should go for surgery. So key is, what is the durability? Now, what we know for sure, based on the data, because remember the partner trial they have done back in 2008-9, and then follow up, the randomization, then initial data. So we have 5 to 6 year follow up. It seems to be that 5 to 6 year follow up, the both randomized group, the tower as well as surgery remains identical. There are actually some data, some show that deterioration is slightly less. If you take the definition of structural valve deterioration of gradient increase of more than 10 or new 20 millimeter, you have numerically slightly lower with the tower valve compared to surgical valve. So that is one piece of data. But only 5 to 6 years. We don't have more than that. Now, knowing that 5 to 6 years, 95-96% do very well, you will say that probably both will be equal. So now, coming back to that point, so FDA was very concerned. So what they did is, in low risk group, in both the studies, they made 200 patients in both surgery as well as in the surgical valve as well as tower valve to do a follow-up 4D CT. So for leaflet thickening and durability. So not only those main endpoint, which will be 1 or 2 years and decide what valve to use, but continuous for up to 5 to 10 years. So answer to your question, simple answer to your question, it seems to be at this time that for a midterm, and midterm I'm defining as 5 to 6 years, that both valves were good. Now, also the data are very clear. That is the hemodynamics point of view, the residual gradient, aortic orifice, consistently is higher with the tower valve compared to surgical valve. You know why? Because we don't have to put that suture in the tower group. And in the surgical valve, because you have to, so and maximum you can get is like 19 or 21. Here, many of them here 31 millimeters. So 34 evolute, you have a valve area of 2.8 and gradient becomes 0. So key is the immediate, the valve definitely do a little better hemodynamics point of view, the tower versus surgery. And at 5 to 6 years, consider true hemodynamic studies in the randomized data that both are identical. So I would not say, and just to come back to, I never tell any patient that the surgical valve lasts 5 to 6 years. If somebody giving that information is wrong. But I do tell them it lasts 10 to 12 years.
So is there any low-risk patient now that you would say should preferentially have surgery, or would you now consider every low-risk patient for TAVI?
Right. So I think that's a very, very good point. So once it get approved, we probably make an algorithm that way. So somebody, the low risk has extensive CAD. We know that this patient is coming back, your engagement with whether it's even with the sapien may have a little higher chance of acute occlusion, and so maybe that patient should go for surgery. Patients with a high calcium, the really annulus, and young person. Some people actually, another thing will come when you have discussion with a patient about the permanent pacemaker. Clearly, permanent pacemaker will be 3 times higher in the tower group compared to surgery. So many patients actually, few of the patients when we had discussion during the trial, they said there is a chance for 12%, 15% for the pacemaker with the tower versus 3-4% with the surgery. They say, I don't want pacemaker at age of 65. I do this exercise, that exercise. So there will be some decision making will come. So not that every patient will be appropriate. So, if you think that patient, very high chance of pacemaker, and that was a clear-cut case. Patient was sent to me. We admitted, we did the cath, coronary were normal, but it was a lot of calcium. Ari actually did the consultation, and I was in India. I called that, this looks like taken all this together, it will be better off with surgery. Yeah, I think that kind of you too much calcium at the annulus, young person, probably better, and patient you're doing surgery in the next few weeks on that case. But I think it will go step by step. But I still think that once it is approved for low risk, that is what has happened in Germany. 80% of patients are getting the tower and 20% getting the surgery at this time. So you take away that bicuspid group. So if you take the bicuspid group out, So bicuspid actually registry, both. We actually were ready to start. The patients with the intermediate to high risk, bicuspid registry is also starting. The sapien has it, the core valve will have it. But if you take the bicuspid out and remaining patient, I would say probably it will be about 70-30 or 80-20, just because of the preference. And it also depends that how much benefit will come in March. It is like a few negative points on the tower side. The enthusiasm will go other direction. So I think it's just we have to wait for this. But yes, what is happening in Germany, I think probably will happen in the United States also. And that is, in Germany at present, the surgical valve, the tower is done in all aortic valve replacement in 80% of cases.
Can I ask about, going down your list, the Sentinel device? So are there any off-label uses of this device? So it's obviously got a labeled use for transcatheter valve replacement. Are there other cases you're using it for? But most importantly, as surgeons, could we use that device? So let's say I have a patient with a bicuspid valve, a lot of calcium. Could I have you put one in the cath lab, and then I do the surgery, and then we take it out?
Yeah, many surgeons actually are doing it. Some people are doing even for the mitral clip. If there's for some vegetation some densities on the valve, so mitral also being, but many people can use off-label. We use off-label all the time. Even the first stent when we use for the vein graft, we use the biliary stent, Palmer's stent put into the vein graft, so crimp on the balloon. So approved, once the device is approved, off-label is very common. And this, some case when surgical concern, although that there are two data on these protection devices during surgery, both have been unsuccessful. They did not show the data, positive.
The same as Sentinel, that was also a negative trial, but it was approved on the basis of the particulate matter and the likelihood that it will be beneficial.
And subsequent data have been very, very positive. So question is that can you use the Sentinel device for your high-risk surgical case? You think higher chance of embolism? I would say answer absolutely yes, as long as anatomy is correct. Gilbert, what do you say on that?
I think the issue though, when you're on bypass, you don't have pulsatile flow. And these filters, there's still a risk of, despite adequate heparinization on pump, you just don't know what the flow characteristics is across the neck vessels. But there are other, as you know, other cerebral protection devices coming down the pipeline. One is femoral approach. It's like basically like an umbrella that shields the entire aortic arch. So everything's just deflected rather than trapping the debris. So that one might be more amenable to open surgery because you just don't know what, cross-clamping the heart and putting on bypass would change the flow characteristics on the neck vessels.
No, but I can tell you that Raj Makkar from Sinai did mention to me that they had done, this was in September last year, that a few cases, the surgeons have used it. They asked surgeons to do the same, that they thought very high chance for embolism, and he inserted the valve.
And also depends on how long the surgery is. We typically, during the TAVR, we don't leave the Sentinel device in the neck too long. Once it's engaged, the clock's ticking, we like to just get the valve deployed and then remove it. We just don't know how long we can theoretically leave it in the neck vessels for. Because there's no data, right? Obviously, this device was done in the transcatheter world, not in the surgical world. But to your point, Ani, that people have done it off-label on transcatheter mitral cases like valve in MAP, valve in valve, where obviously the surgical valve has a lot of debris or panic, just like the aortic valve in valve, and they have done it off-label just in case of embolic risks.
So, but let's say we wanted to do that. That would mean the patient first going to the cath lab and then.
Yeah, ideally you'll be but you need the radio access and you need to give some heparin already just to make sure there's no clot developing. And you would, ideally hybrid OR would be the best place because you can just put it in and you can start the case. But if not, then you would have to put in the lab, and then you have to keep the device sterile because you have to remove it afterwards. And then you would have to bring the patient to the room. So logistically, it's going to be a bit complicated because that device has to remain sterile so that you can remove it in a sterile manner.
And the question is, once your new OR, hybrid OR room 23, maybe that will be a little better suited for this kind, so they could do full surgery. Yeah. Because I don't think we are doing routine surgery in 26 at present, right?
No, we can't. It's not a proper.
So question is maybe 23 should be put for that.
Yeah.
23. So otherwise logistics will be a little difficult. It has to be done under fluoroscopy.
Yeah.
And even before fluoroscopy, patient has to have a CAT CT. To see, because otherwise it'll be very futile. You'll do more scraping. So just by CT, because we are part of it, about 20% will be excluded because of the anatomy. You will not be able to the 20 are gone. So remaining that 80, you'll be insert in about 70-75% of them because of same spasm of the radial. Can you only go through the right radial? And so it just a little, still technically a little challenging. In the past used to add 10 minutes, but now we get very good at it. Live relay, we showed it that 3 minutes. It took only 3 minutes to deploy the sentinel filter. So key is that yes, you need to have a CT beforehand in that particular case, and then it will require fluoroscopy, and lastly, the radial artery has to be present. So
I think surgically we can access the axillary artery, which is in our field. So even without the radial, we could go straight through the axillary artery, and you could deploy from there.
Yeah, the catheter is quite long, so it'll be more or less like the old days where you use a transfemoral system for like a direct aortic or subclavian. So you would have to really set up the room such a way you can leave that whole system exposed in a sterile and cover it up during the case. But I think the better device might be the TriGuard, which is femoral approach. You don't need any special access. Most of the people would have femoral access, and it's just a deflector in the arch vessel, so you don't need any aortic, like net vessels manipulation, and you don't even technically need a CT scan to look at the net vessel. And that's under trial right now. I think Columbia is trialing that. But if you're interested in that, we should talk to that company to possibly do it in the surgical arm. So I think that's actually a safer device.
That's a shield. Just cover entire all the great vessels.
And it's like
everything
is French catheter.
You don't have to worry about it. Femoral. Don't have to worry about the special CAT scan and so. So actually, Roxana Maran was trying to get it. Again, many of these things are very highly politically assigned. So they're getting it. But yes, TriGuard will be another one which will be a new in this field. But now the Sentinel now we got some reimbursement. Before there was none. It cost about $3,000. So now we are getting about $1,500 to $1,800. So I checked it. So we are getting about $1,500 to $1,800 reimbursement for the device. It's still not complete, but about $1,500 to $1,800. Yes.
Dr. Sharma, we talk about putting these in younger and lower risk patients and the durability issues. What about valve in valve? In terms of TAVR in TAVR, do we have any data at all about people who've had a TAVR in the first place? There's been structural degeneration, and another TAVR is put in years later. What kind of data do we have about that, and what size constraints? When we there was like a 29 valve that got a 23 inside it. Now that seems like a huge drop in size. And what size constraints and what sort of things come to your mind in terms of how do we rescue a failed surgical valve? How do we rescue a failed TAVR valve?
That's a very good point. I think we actually have experienced about 5 cases so far where we have done TAVR in TAVR because of whatever reason. One actually was the recent unfortunate case where you also develop annular rupture after putting a sapien because continues to have paravalvular leak after the evolute. But otherwise, we actually have done, but there are no formal reports. There are only case reports for this. So no, like series of 12 cases. See what happens. What is the residual gradient? No one knows. So case by case, you study what need to be done. But you're clearly, the second valve will be smaller than the first one. And that always will be the limitation. But there are case studies. And the first actually was published almost 5 years ago in JACC intervention. So they had a sapien valve which degenerated and they put a core valve inside. So that was the first case ever in the literature in 2014. But since then, even our center, we have 5 cases so far, and they all have done okay. Means nothing, not that they have a high residual gradient, and so they did whatever the purpose was. Elevate that gradient, whether or paravalvular regurgitation, they have done quite well. But anecdotal case reports, no series publication to really understand a better long-term data or immediate hemodynamic data with these valves. the degenerated tower valves. So therefore, the question comes that age of 60. Now, question is, what should be your start point? Some people will say, why not we do the tower at age of 70? This degenerate, maybe then do the bioprosthetic surgical valve. Now it degenerates at the age of 80. Now you can put a tower. I'm just saying there's a lot of different camps. The other person says that if you do one tower, bioprosthetic valve at age of 60, if it degenerates at age of 70, you put a second tower valve. So now at age 80, now you're in deep trouble. You cannot put 3 valves in one patient.
The problem, Dr. Sharma,
One surgical, one tower, and then one tower.
Yeah, the limit is 2. That's sort of arbitrarily. There's only 2 that you could possibly do.
I guess so. I mean, I don't know. Maybe it will cause more coronary occlusion, theoretically. Yeah.
Dr. Sharma, the problem is you have all these young residents at the back, and you're taking away all the aortic valves they used to do. So you're going to do all of them with the catheter. So there'll be no surgeons to do this, your AVR after a TAV valve. So to take out the TAV valve and do a surgical valve is a hard operation. So who's going to learn? How can we do that? The residents don't see AVR anymore.
I mean, that definitely is the big... But again, there still will remain, as I mentioned, 20-25% of cases, if we just follow the German, the acceptance, that it still will remain at particularly young age, bicuspid, all those experiences will still remain. But I think the issue of what should be the valve start at age of 60. Once it gets approved for the low risk, will be the issue. So I told you that we go to all the meetings and everybody has a little different discussion that what to do. So if you put the idea is you do first, maybe, and of course Dr. Adams just arrived, that you do a bioprosthetic. Now it reached nose at 70, you put a 1 tower valve. Now at age 80, what you do? So some people are saying, encouraging, I'm not making that, I'm just saying that what is the out people talking. So what we do at age of 60, tower valve. Degenerate at 70, get the surgical bioprosthetic. That get restenosed at age 80, you can retower. So anytime you did not have more than two valves, 2 prosthetic valves.
See, the problem is that everybody forgets that you don't live your normal life expectancy when you get an AVR at 60. So you're not going to fail at 70. When you look at a curve, half the people fail, a quarter of them are dead. So all this hypothesis is built around a 20 or 30% population, not 100%. And that's the problem. The way we talk to valve patients is that we just presume everyone is going to survive to their failure and they're all going to fail. Actually, very few of them come back for reintervention. If you think about all the bioprosthetic valves that were put in this institution the last 20 years, and how few of them we discuss valve-in-valve or reoperations on. It's a tiny fraction of the ones that went in because they don't come back. And I think that my 2 cents worth about that is that the screening, it's going to move away from risk and more towards screening. If you have a straight shot, a good-sized femoral artery, no disease in the arch, a perfect size match, then you can say, well, your durability, we'll have to see. We won't know that for 10 years, but the durability might be a reasonable bet if you're in your 60s, and especially then if you are a typical American and have a BMI of 30 and all this other stuff that goes on, then I think that's going to be the kind of patient that gets TAVR. If you're a 60-year-old chairman of heart surgery, loves to play golf, very healthy, never spent a day of his life in a hospital, I might still get the surgical valve. But I think patients are going to make those decisions. Whereas if it was my older brother, one of my brothers who's a giant guy, and it's just, a much bigger deal to do surgery on him, it might be lower. It's just anatomy, I think, is going to be a bigger determination than risk going forward. I think
those are the important will be that what will be key is the appropriate case of the low risk in that age. That's a classical, we're talking about age of 60. Has to be that your complications are less than 1%. Just like the Ron Waxman's data. That your mortality, CVA, all those we're talking about less than 1%. Now, pacemaker will still always be the issue. And that actually, for many patients, knowing that no longer now CVA issue, knowing that both are identical, numerically maybe even lower with the tower, this issue in the younger group, many of those patients declined just because they had 3 times more chance of pacemaker with the tower versus surgery. So they opted surgery for that purpose because nobody wants to have pacemaker at the age of 60 and be a normal functioning.
Yeah, but I mean, that's the other question is, would you, like everybody in this front row, I mean, if you're going to get us, I'm only picking on you guys because we're all the older group. We don't have to go up the stairs. The pacemaker. How do you discuss that with patients today? Because I mean, most physicians gloss over the bad things and just talk about all the great things. You know, robotic surgery. It's not even surgery. It's just robots. It's still open heart surgery. You're on a heart lung machine longer than you would be the regular way. But we just talk about it's something else. So that I
can tell you, just coming back to the robotic, this guy that's NYU with the mitral, he's making a big waves. Every patient coming with the mitral, that robotic and all, they have just done with a big publicity on this robotic mitral.
Oh no, but that's just the left side of Google. If you look at that's just how much money you want to spend. If you look at robotic, which I'm interested in everything, but if you look at robotic surgery and the impact of mitral surgery, it's actually declined every year. It's a 17-year-old field. There are less centers doing robotics than ever now, meaning there are a few really high-volume centers, this one included, that's interested in looking at everything every year. But the number of centers that do robotics is minuscule. They just closed their program at New York Hospital after all this fanfare of bringing someone here 2 years ago. Literally in the last month. And so it's one of those things where it's a market, it's great. If it's done really well and really selected, it can work. But for instance, at Cleveland, where they have the biggest robotic program in the country right now, they still screen out 70% of people, 60% of people. You have to have an absolutely simple valve with absolutely no risk to have a robotic operation in Cleveland, which is the model we would follow here. But I think that's I think the other story about that was interesting in COAP, and we're going to learn a lot more about that at ACC. There are 3 sub-studies being presented about, further narrowing the selection of who should get it and who shouldn't. But the biggest lesson in COAP was the importance of medical therapy. Remember, half the patients in the medical arm, their MR got better and their heart failure symptoms improved in continued medical therapy. And to get in the trial was 3 months of GMTT. So you had to have 3 months. And then in that period, a lot of them fell out before they got to randomization. That's why it took 3 different protocol variations in 7 years and 80 centers and who knows what to enroll a trial where there's supposedly millions of heart failure patients out there. And so the guideline medical therapy is probably the biggest story in the FMR. And the way, which I say to all of you guys in the front row, what's changing in practice is if you come in with heart failure related MR, you're not going to start with that. You're going to get referred the patient like we do in this clinic for surgery. Or for whatever, clip, surgery, something, do something. But the first thing you're going to have to do is get EP to see them and get heart failure to see them because it's 3 months away from doing anything. And I can promise you that's what CMS is going to say. The inclusion for a clip will be exactly the inclusion for this, which means you will really have to document guideline medical therapy. Because at least half the patients will not require either intervention, surgery, or clip with guideline medical therapy.
And that actually exactly what happened in the co-op. That what happened is, Dr. Adams pointed out, with the medical therapy, they feel maybe a little better or not. What happens, the MR decreases. And if you had 2+ MR, they were not part of the trial. So that, and I'm sure once the guideline will come, the gatekeeper here will be the heart failure. That heart failure team has to see patients 3 months, and that is what they did, maximize the therapy, and they are the one, just like for current mitral clip for degenerative MR. It is only the surgeon has to write that it's a prohibitive surgical risk. Then only they can get the clip. So in my opinion, with the guideline, it will come. It is a heart failure person has to write the tried therapy for whatever time will be 1 month or 3 months and failed, and now it's okay to try clip.
Dr. Sharma, I'm curious as to why you have COAPT as the highlight and at the top of your list and mitral FR at the bottom. Is it just because of the results? Like if the results were flipped and COAPT was negative and mitral FR was positive, would you have now put mitral FR as the highlight? Because it,
there is a
goes
paper
to
I
what
just
you
came out last week looking into, I think it was the whole idea of what is your regurgitant orifice, the MR, degree of MR compared to ventricular size. So what happened is that if you follow the patient too long, that cavity became too dilated. So now you're at the end stage. That was the mitral FR case. So that patient clip is not going to work. So this, I think there are a lot of, one paper actually I just saw, which I still have to make the slide on, that what is the real echocardiographic message or interpretation of these two trials. So what I could get the conclusion was the degree of MR based on the cavity size. So key was that in the mitral MR, looks like that their degree of MR was less compared to the ventricular dilatation. In the COAPT, degree of MR was more compared to per ventricular dilatation, means the cavity did not dilate, and we know end diastolic volume was tremendously high, 140 versus 115, so much higher in the mitral FR. So what I said negative here is that we don't let our patient of this heart failure, those and moderate to severe mitral regurgitation get to that stage and catch them. What will be the criteria of the COAPT?
Because I think we feel so confident that COAPT is real and that the results we see there are real. It's possible that it's the mitral FR that's real, or that the truth is somewhere in between the two. But I think we're getting carried away to think that you can treat 6 patients and save 1 life.
Yeah.
With a mitral device. I think it's too good to be. That's better than beta blockers, better than ACE inhibitors, better than defibrillators.
Yeah. At TCT, the hosannas were flying, the interruptions of the crowd, multiple I went to
and Gladstone crying on the stage, but presenting.
And then we went to an investigator meeting that night, and several of the people that are involved in the transcatheter mitral trial were questioning whether it's ethical to still do anything but COAPT and anybody now. Could we still randomize patients? There was this gigantic discussion about how COAPT has changed the world. And I just, there were, excluding a lot of senior people, and I was one of the 2 PIs, so I was making the point that we should just remember where we are, and sort of remember the heart failure community and remember all the other stuff going on here. And sure enough, there's been, the pulse from Columbia, Mike Mack's program, some of the big players around the country is that COAPT didn't really change anything in terms of the heart failure community. There wasn't this gigantic upswing of suddenly everybody getting referred for MitraClips and whatever. It's a lot. It's interesting, and everybody is interested, waiting for more sub-studies of what's the cutoff for left ventricular volume that would look like it will probably fail. And the other big point of mitral FR and COAPT as Dr. Sharma mentions, is the LV volume, the degree of MR. It's actually better to have more MR because, of course, you have a better target and you have a more healthy ventricle. And the third thing is that you're there was no prescribed medical therapy in mitral FR, procedurally. So without better that's where, again, the medical therapy side of this is going to become increasingly important, both pre and post-op.
one other comment was that if you look at the surgical literature with the data from years ago from Robert Dion, was that in the patient with ischemic MR, if the ventricle is greater than 65 millimeter, the rate of failure was higher. So, 65 is not a huge ventricle. And if you look at the CTSNet trial, when they said putting a ring or medical therapy didn't change too much because these ventricles actually were on the smaller sides than on the larger sides. So the question is, a lot of these heart failure patients have large ventricle, which is more than 7 centimeter. And therefore, either you do clip or repair. It might not be the right thing because, as you said, there are two way out and burned out.
But I can tell you, mitral clip from the FDA perspective or industry perspective has made a lot of people very nervous. Because, with the 10-9, the Abbott wanted to go with the randomized. Now everybody thinking that maybe FDA will mandate that your randomization should be against mitral clip. What will happen? So, it has made a lot of people nervous.
Yeah, but 10-9, Abbott got out of 10-9 because they just are in the final. The Abbott got out of 10-9 because there's changing devices, not because of the the randomization part of this. They're changing devices, but I think that was another question: is in the future what would be the right way to randomize, because you will have less MR with a replacement device.
Yeah.
And you will have, certainly you'll have less MR. But remember, you just have to put a couple more things in perspective about this trial. I told you it took how many years? 6 or 8 years to enroll 1,000. Literally, you talk about millions of heart failure patients, and it takes 8 years and 80 centers and all these things to do it. TAVR trials enrolled ahead of schedule, every TAVR trial. This trial took 4 times what they thought it would take to enroll. And that shows you, one, about the medical therapy, how effective it is, and 2, just how selective. This was ultra selective, meaning you didn't just go in there and keep your fingers, we can try, you're 80, let's give it a bang. It was like you have to have perfect anatomy, screening committees, this and that and whatever, and then you only got in the trial. So the results were predicated on unbelievable discipline selecting mitral patients, much like Neocord. We could have enrolled Neocord in 1 year if we didn't want to have discipline about the type of posterior leaflet prolapse we were going to treat. That's why that trial's in trouble, because if you really want to select patients super carefully, you got to be willing to do it over 7 or 8 years in the mitral position, because it's not one lesion like aortic stenosis. And I think that's something that's lost. And then the second thing is, what percent of patients in that COAP trial were implanted by the top 6 implanters?
Majority of
70%. So 70% of these patients were implanted by the busiest MitraClip implanters in the United States. They're actually very different than the TAVR trials. Edwards was 13 or 18, and Medtronic had like 22. This was like 6. So this is it's really important data, because it was the first evidence that treating MR might affect quality of life in heart failure. That's the first. That's a monumental finding. But this was the best of the best, doing the most selected patients with the crispest post-op medical therapy in history, and then you got a great result. So that's why I say, institutionally, we have a real message there. If we have a gigantic responsibility to do MitraClip and FR patients. That is to get the results that we want to tell the patients about. We're going to have to be very disciplined in preoperative management, who we select based on anatomy, and postoperative follow-up. Otherwise, we're never going to be able to even pretend like we could duplicate those results, because these are really good results. And I'm actually I'm really happy that they came out, and we're talking a lot about it at the AATS this year. We have several sessions about COAP and MITRA-FR, because it's just an incredibly important data set, and we're going to learn a lot in New Orleans. We
talked actually 2 days before the TCT. We're doing Apollo case with David. Remember conversation? Yeah. I said, I don't know. This looks like that co-op will be very positive. I didn't know, but nobody knew. I said, but everybody we're talking, they're like smiling. I said, maybe. He said, and David said, how can it be? MITRA-FR was negative. And I said, I don't know. But to me, this was clearly a
Selection. Yeah, it's
volumes. 2-3 days before the trial was presented in TCT, we had a discussion. I said, I don't know. Everybody's like smiling, those who are involved in this field with, and it truly.
What's going to happen is there's going to be there are other trials coming, and like I say, there's a really interesting data set, and we're going to see a lot more about this over the next month or two, I'm sure. I mean, I think when March comes, we'll learn a lot more about this, and then again, I'm on this roundtable with CMS. There's going to be a guideline committee's been put together. That Pat O'Gara and Bob Bono are leading, and there are going to be about 6 or 8 more representatives on that. And we have a writing committee and working with CMS to sort of come up with how all that's going to lay out. So it'll be really interesting to watch how that evolves. But we're clearly going to see these in the guidelines and clearly going to have a separate writing. We already have put together a writing committee to start to talk about that. Should be fun.
All right. Thank you very much.
Thanks, man.